Hello, everybody. It's Dr. Andrew Gums. This is episode 55 of our podcast slash webcast, Artificial Intelligence and Cybersurgery. I'm here with my co-host, Dr. Vincent Grasso, who will invite our next guest or introduce our
Fantastic.
next guest, excuse me.
No, it's great. And thank you for taking the time out on Saturday. As Andrew said, episode 55. It's Dr. Christian Cotsoglou. He's a surgeon in San Gerardo Hospital in Monza, Italy. He's a hepatobiliary surgeon. I believe that you trained in Milano, Christian, correct? And
Yes.
It's great to have you on, talk about AI, talk about your work, and please to give our audience a little introduction about yourself in some more detail. Welcome to the podcast.
Before you start, I thought Vincent was going to say a little bit of our catchphrase. It's just that our journal is the first journal dedicated exclusively to artificial intelligence and surgery. So we're very happy to have you. Go ahead.
Thank you very much, and thank you for the kind invitation, Professor Goops. And it's a big pleasure for me to be here today in this very, very nice podcast. So I will start with my name. My name is Cotsoglou or Cotsoglou. That the difference is between this is because I am for half Greek, for half Italian. I was
Where's
born
the
in
Greek
Italy.
half from?
My father is from Athens. My mother from Ioannina. But we have a very nice house in Skiathos, a very nice island. Right. So in my heart, I have these two components. But I was born in Italy, and I study here in Italy. So I graduated in medicine in 2002 in the University of Milan. But after I did my residency in surgery in the University of Milan. But the real inspiration is when I start my career in the National Cancer Institute of Milan in 2005, where I met my mentor, Professor Vincenzo Mazzaferro. And there I used to stay there for 15 years as a surgeon in staff, of course, where I learned liver surgery, hepatobiliopancreatic surgery, and liver transplant surgery. So at the end of 2019, I started my career as a chief in a small but very nice hospital in Brianza, close to Monza, Vimercate Hospital. And from May 2024, I'm the chief of the second division of surgery in Monza, San Gerardo, Monza. And my specificity is, of course, the HPB surgery.
Before you continue, I must ask you, yes. What are your thoughts about Lewis Hamilton joining Ferrari?
Yeah, well, I think that is a very, very good thing because Lewis Hamilton is probably one of the best drivers all over the world. Is very surgical, of course, very precise. So I love it, and I would like to see the next year. You know, every September we have the Grand Prix in Monza, so maybe you will come to see this with me.
Oh, okay. Nice. Yeah, maybe I will actually.
Okay, we can do it. We can do it.
Great.
So this is my career in an abstract of my career, of course. And now we have started a program from Vimercate and, of course, in Monza of 3D rendering for HPB surgery and especially for the liver, complex liver surgery.
So, you know, I get approached by a company that does 3D rendering every couple of months. You know, a lot of the CT scans, if you pay for the add-ons, the software already exists to do 3D rendering. How is the 3D rendering that you do different? Are you working with your radiologist to do it? Are you working with a private company? Are you working on yourself with the 3D rendering? I know some surgeons that they download software and they do the 3D rendering themselves. So what, you know, are you doing segmentation too? Any radiomics? What do you focus on right now? How you do it is what I'm really most interested in right now.
I tried a lot of paths, but at the end of all, even because of the lack of time that we have every day with congresses and operatory rooms, etc., the best way, in my opinion, today is to approach with a company, because the company has a multidisciplinary approach. The big difference between a cosmetic 3D rendering and a real instrument for our strategy is to have a multidisciplinary approach. So the HPB radiologist, the HPB surgeon, the engineer inside, they can merge the competitions of each other, and they have the best way to be very accurate, even in the preoperative process, even in the interoperative navigation, and also sometimes if you want to see, for example, some specific conditions as a vanishing lesions, for example, as the possibility to perform an R1 vascular resection. So I think the best way is to take some contacts with very, very serious companies. Now there are a lot of them. I will not show you the brands, of course, for obvious reasons.
Well, actually, if I have no problem of giving them some publicity, if you want to or if you're not, I would actually like, it would be interesting, I think, for some of our listeners to figure out who they could contact and kind of what is the workflow that you go through to get the 3D rendering. Are you doing like a research project and developing a business and you don't want to talk about it? That's one thing. But if not, if you're able to talk, even give a website of who people could contact, I think that would be great.
Generally, what you do is to give to these companies at least 4 days before the operation, or before when you need to have this 3D rendering, a CT scan with very specific slices, because they have to be more accurate, and then they try to understand what the artificial intelligence can create and generate, and then the human being, even today, is absolutely mandatory to perform some changes in very small vessels to understand exactly the comparison and the position of the tumor, if it's close or not to the vessel. So we did
now,
also.
Do they have a radiologist that will do all of this for you, or do you have to sit with them and tell them where the tumor is?
They segmented and they have a radiologist. We just give MRI.
Do you have to pay a fee? Does the hospital pay if it's a fee, or does the patient pay, or does the Social Security pay?
No. You have, as hospital, to buy a sort of a package of 10, 15, 20 different,
Units, yeah, I understand, or patients.
So
yeah.
It's not. It's a little bit. It's expensive, because you have to work. It's a lot of people that is working for. If you want to have, I think, something different, something more from the CT scan, you have to pay. This is, I think, something very natural. But the other thing that it's very fascinating, the other challenge for me, is to demonstrate. After we demonstrate with our article, we did a sort of multi-center survey in which we demonstrate that if you give to 25, 23 raters, very experienced surgeons, HPB, you give them informations for some patients just with CT scan, we don't have the same accuracy of the reality compared to the reality that you have when you give to these raters the 3D rendering. So when after the 3D rendering work, the surgeon has exactly a very close perception of the anatomy. So this is one very interesting point. But now I would like to demonstrate if 3D rendering can help us to perform some dynamic anatomy, so some dynamic movements, as for example the hanging maneuver, as for example the passage of the pancreatic body between the pancreas and the vein. So,
and you're talking preoperatively, not during the operation.
Yes, of course. And if you can't do this, you will not be risky to try to do this by sensation. So it's more easy because it's 3D to generate a sort of line from the point A to the point B, and you can understand if you will have the tumor close to you or not. So I think that is the best way for the surgeon to know if he will perform. It's good to try the way of, for example, the hanging maneuver, or it's too dangerous. And that can standardize also the maneuver without, having the perception of I can pass, I cannot. I think it's a very interesting point of view.
So which patients do you use this technology on? Obviously, if you have an anterior lesion in segment 3, very superficial, you're probably not going to justify it. But maybe I'm wrong. Are you using it in all of your patients? Are you using it in certain types of tumors, only lesions next to the larger vessels? Which patients right now?
You can use it whenever you want, but I think that you have to uh, demonstrate the cost for very complex surgeries, very complex or very difficult lesions close to vessels. So that can help you. There are a lot of other articles that demonstrate that you change your route in 30% of the patients.
Wow.
So it's before to know this. And also you have a better perception. Also, if you have to perform some reconstruction of the vein, for example, in the cracked skin tumors, sometimes you have the infiltration of the vein, of the portal vein, that you have to maintain. Knowing that before, and believe me, in with the 3D rendering, especially in Klatskin tumors, it's very easy to understand this because you remove the noising, you remove, the biliary duct, the parenchyma, and you just see the tumor close to your portal vein. Knowing this before, it's very useful because you can choose your strategy, you can choose your team, you can choose your better nurses, you can take your graft from the bank of tissues, and you can do everything with a very precise condition. This is different if you are at 6 in the afternoon and you understand in that moment that you have to remove the porta and you have to perform an anastomosis, very difficult. So even the complexity, you can program the complexity before.
In an ideal world, would you have this technology for every lesion?
No, in ideal world, I will do this just when the lesion is close to the vessels, or if I would like to see some vanishing lesions position, because you have of course the ultrasound, but you can use this kind of technology even in an intraoperative room, and in that case, you can put the 3D rendering of the CT scan before the response of the chemotherapy, and you can see exactly your landmarks, anatomical vascular landmarks, that you can find it with the ultrasound. So I think it's very special.
What about for parenchymal sparing liver surgery? So you can, preserve as much as you can. I would, you could make the argument that even for small tumors, you could maybe get some benefits, so you could really find the feeding vessel and what have you. But what do you think of that?
No, it's another very interesting condition, I think, to use the 3D rendering, because you can understand if you can remove the tumor from the vessel, or, for example, if you will perform some radiofrequency ablation before to start the transaction. So it's the other I think very interesting application of this technology is also for uh, you can talk with the patient, or you can talk with the parents,
And show
even
them, yeah.
show them exactly the risk, exactly how it's difficult, because you have also the 3D object.
With all the blood
So
vessels around, yeah.
it's the best way if you don't have the ability to draw, but it's the best way to explain how it's risky, this operation. And even for our residents, they learn more and more quick So I think it's an interesting point of view.
Yeah, it's funny. The older I get, the more and more I rely on imaging preoperatively. I mean, which you would think would be the inverse, but it's like the older I get, the more and more I appreciate it and want it. Now, talk us through a little bit the process that you went through to get it approved by the hospital, because at the end of the day, does the extra money come out of your department, or does it come out of the hospital's budget? Because you're the head of your department, were you able to get it approved easier? Did you still have to go through some committees or anything? Like, I think it'd be helpful for people to understand the complexities involved there.
The best way to talk with the hospital is to perform a cost-effectiveness program. You have to demonstrate that there is a cost, but you have lesser complication, lesser hospitalization. So you have to demonstrate with numbers that the specific patient, highly risky of complication, will have generally a better outcome, and so you will have a less cost in terms of the hospitalization. I know it's difficult because when we talk about high complex HPB surgery in general is not convenient for hospitals, but it's the only way to demonstrate that you gain back some money. I don't know if the way to say is correct.
This is actually so interesting because I am an advocate of having one person in every surgery department with a master's in AI, or perhaps even a PhD in AI, and that goes against what a lot of other AI people say. They think it's not necessary, but I actually I think that's the future. It's going to be like in radiation oncology, where they have a physicist in every department. I think every surgery department one day is going to have an artificial intelligence, surgeon or non-surgeon, but on staff there. But, it reminds me of something that Vincent convinced my brother-in-law to do, actually, which is to do an MBA. And talking to you, I'm realizing that every surgery department probably needs one surgeon at least with an MBA nowadays. Otherwise, you can't progress. You can't explain to business hospital executives why you need things, because they don't care about clinical results anymore. I mean, that's not the number one. They care, but it's not the number one priority. The number one priority is dollars and cents. What do you think, Vincent? I mean, I kind of after all these years, I might get that MBA you've been trying to convince me to get.
No, I mean, this is very interesting because if you can't make the business case to handle the expense, you can't make the business case to the finance people. If you can articulate it in a language they understand formally with a cost benefit ratio analysis, etc., as Christian is mentioning, they say no. And what's interesting is there's only a limited amount of funds that a hospital has, right? It's fixed. And if you have departments competing for funds, the department that's the most articulate in presenting the business case will have a better chance of getting the discretionary funding than another department, right? So everybody's fighting for funds. If you have a department that has an MBA surgeon, MBA physician, and you have an artificial intelligence, you have a technologist that can help them construct the argument, you have the best chance of getting the funding. So I think this is the right time for this discussion. And Christian he has to do it himself. He's making the case for the advanced technology cost. He has to present the business case, and this makes perfect sense.
Christian, I'm very interested in, you're very passionate about this topic, which is fascinating because it's a surprisingly big topic. I actually wonder if maybe one of your residents would be interested in formulating, I'm not sure, either a survey or even almost a checklist of what is needed for 3D rendering, like criteria, something that maybe you've already done when you've talked to your administrators, like, look, I want 3D rendering for this patient, for this problem, this. I want to do 10 patients, a cost analysis, and I want to show the benefit. I mean, you've mentioned you published something like this, but if there was something that could help readers already talk to their administrators, I think it would be an interesting paper. What do you think?
Yes, I think it's the point, but
Like a
I
white
don't.
paper on like how to get 3D render, why 3D rendering in liver surgery needs to be in liver centers, something like that.
Yes, it's very interesting. The only difference is that in Italy, we have, I think, two different points of view. I mean, what is my perception? I used to work in public hospitals. So, public hospitals, you can go to your president and you can say, okay, I have to expose my project. I would like to perform 20 patients. The cost is, yes, is very high, but I will show you with the cost effectiveness analysis that it's good. I don't think that the same discussion is it's easy to perform in private hospitals because they have more attention to the costs. So it's something that we have to distinguish. But I think that is a good way is to explain to the bureaucracy of the hospital that why we decide to choose that, because for them CT scan and 3D rendering is quite the same thing. So it's difficult to explain that, but we have to do it.
Yeah, absolutely. No, absolutely. It's more and more we're going to need it even more. And then that brings us to radiomics. Are you using, or do you have any plans to use radiomics, an analysis of the voxels of the scans to determine preoperatively biology, maybe aid in diagnosis? Do you have you're in a private hospital now, so you have residents. Are you still able to have PhDs and researchers, or are you involved with the university? How does that work for you?
My division is not an university division, but we have residents,
Yeah.
and we can also find the funds to have some people that can help us for that. And we don't have in the hospital a radiomic programs right now, but we collaborate with AIMS Academy
Yeah.
of Niguarda for a program for the cholangiocarcinoma, for the mass forming cholangiocarcinoma, and the use of radiomics with the University of Modena. And in
Nice.
that we will would like to see if radiomics can help us to find some perception of the nature of the tumor before the biopsy, or avoiding the biopsy, for example. So I think it's a very interesting point of view, even that.
Yeah, there's imaging and surgery are becoming more and more married every day, it seems. So Vincent, I'm going to let you close it out. Do you have any last questions for Dr. Cotsoglou? I love saying that.
No,
Great.
It's
no, it's
funny.
very.
When I saw your name, I initially thought it was Romanian. But it's Greek.
Greek 100%.
Very, very, very Greek ending. Okay, so that's my mistake. Okay, go ahead, Vincent. Sorry.
Sure, no, that's exciting. We'll continue the conversation. I think, Andrew, we've talked about 3D rendering and the whole radiomics bucket, so to speak, and how important it is for surgical planning, etc. So this is episode 55. Dr. Christian Cotsoglou, hepatobiliary surgeon and doing very interesting things in 3D. As Andrew said, we are the only surgical journal dedicated to all things AI. And we'll have you back on the show to talk about some more technology advances at your facility. So thanks for the time on Saturday.
Thank you for the invitation. I'm very happy.
Thank you both.